we actually have more now. We've screened over 3,000 3-year-olds, which was 53% of our target population. So our target population is all the 3-year-olds, all the 5-year-olds, the 10-year-olds and 13-year-olds who came into clinic and checked in and could have gotten a screener. Because there's tons of 3, 5, 10, and 13-year-olds who never come to our clinics. They're members, but they didn't show up for their well child visit. So we chose to just pick the kids who actually checked in for their well child visit, and 53% of those 3-year-olds actually got screened. 5-year-olds, about 2,700 5-year-olds were screened. That was also 53%. The 10 and 13, we've only been doing that for under a year. So we've screened about 500 of each of those, and those, the target population, we've gotten a little less of them. I'm not sure why. We may just have to go over the workflow again with our receptionists and our staff, but that's the numbers that we got. And then, interestingly, only 7 patients were recorded in our health record as not answering the questionnaire. And what that tells us is that if the patient actually gets the questionnaire, so that like 53 or 35% of the patients who actually got it, we have a 99% completion rate. So if they're actually handed the questionnaire, almost everybody actually does fill it out, which is kind of nice. And I think shows that patients are comfortable utilizing it. And then, so our screening rates really varied across medical center locations. Again, I'm not sure if that's because of the workflow variations. I'm not sure if that's patient population. The medical centers that volunteered to be a part of this, it's great because they're actually all vary quite a bit. Downey, where I am, is a little more maybe blue collar and like upper middle class. West LA has a much larger African American population than the other medical centers. Antelope Valley is very rural and has a lot of blue collar patients. Orange County, we had 2 clinics who actually differ from each other. One is a little more wealthy, one is a little more working class. So it was interesting to see some of the variation. And again, we haven't fully analyzed the discrepancies and the variation, and if it's based on race or income or workflow. So for the 3 and 5-year-old well child visits, the screening rates in Orange County were about 48%, Antelope Valley was about 57%, West LA was 61%, and Bellflower was 73%. I think Bellflower was higher because we've been doing it the longest. I think people got more comfortable with it early on, and I think we were probably like more stringent when we first implemented this. But that's the numbers there. And then for the 10 and 13-year-olds, Antelope Valley just joined in, so we didn't have their data yet. But West LA, Orange County, and Bellflower were 28%, 42%, and 45% for the older kids, so a little less for the older kids. And then we looked at the prevalence based on if they were positive screening, how many of these kids are positive by age group. So the 3-year-olds, about 15% of them had an ACE score of 1 or higher. We chose not to break it down by ACE score. And the reason for that is because, I don't want to say it didn't matter, but I've had patients with a score of 1 who, it wasn't just separation or divorce. The 3-year-old with a score of 1 had a drug-using father, or the 5-year-old with a score of 2 had a father in jail and an uncle who lived in the home with mental illness. So we didn't want to just say that a 1 was insignificant, so we chose just to say if a 1 or higher, it's positive, and we're going to look at that. So the 3-year-olds had about 15% positive scoring. The 5-year-olds had a little more, about 17.5% positive score. The 10-year-olds jumped up to 30%, and the 13-year-olds were about 34%. Yes?
I was just wondering, how high is the divorce rate in California?
I think it mirrors the rest of the nation, it's about 50%. Yeah. So this follows the national data that's already out there, and now we just show it with our Kaiser population, that as you grow older, you accumulate ACEs. So the older kids had more. And then we looked at the percentage of children who screen positive by medical center and age. So similar results, but so this is where I was talking about. So West Los Angeles had a lot more positive rates than everybody else, and I'm not sure if that's because of their workflow difference, where they were going over the questionnaire with the MAs and LVNs, or if it's the demographic that's there. I'm not sure. But this is just an interesting way to look at the variation between medical center. And then this is one where we looked at which ACE score they had. So for this, we did break it down by ACE score. And what we found was as the ages increase, the number of positive ACEs 1 or higher goes up, right? But interestingly, the amount of ACEs also goes up too. So it's not just that more kids have ACEs by age 10 and 13, it's that they're accumulating how many ACEs they have, right? So by 10 and 13, there's a lot more kids who are having 2, 3, 4, or even 6 or more ACEs. Whereas the 3 and 5-year-olds, hardly any of them had 4, 5, 6 ACEs. So as they get older, not only are more kids screening positive, but the ones that are screening positive are accumulating their own ACE score as well. So our learning
breakdown from that from the different locations.
No, but we could, yeah. So our learnings from this, one was how do you build this into such a large organization? And again, as I talked about earlier, I think forming important partnerships with leaders. We had a very supportive leadership for this work. Our regional lead who oversees all the quality issues at SCPMG was just all in and was like a yes man for us. It was kind of incredible. It was like, I want to do this, yes. Can I do this? Yes. So, okay. So forming partnerships with higher ups who can kind of he gave me more admin time to work on this, which I'm a full-time pediatrician, so without the admin time, there's no way I could have done this work. So forming those higher level partnerships is pretty critical. Support from local leaders, so my own chief in the clinic had to buy into this and say it was okay for her pediatricians to participate in this. And then our social work team, our MAs, our department administrators, I had to get buy-in from all those people. And then as we spread out, getting buy-in from the other pediatric chiefs. So we did a lot of presenting on what ACEs are to all these people. And I will say, that actually wasn't that hard. The buy-in part, as soon as I presented the ACE science, everyone was like, oh yeah, we need this. So I was pleasantly surprised. I was ready for more of a fight to like, oh, I need to do this and input it. And as soon as I presented the science, everyone was really saying, yes, let's do this. How are we going to do it? So that was nice. And then working with your health record staff, so creating diagnosis codes that didn't exist before. We created the patient information sheet and it had to get approved and edited and done at 3rd grade reading level and all this stuff. And then which questionnaire you're going to choose, which age you're going to choose, all that stuff I went over. So it was multifactorial in making this work ahead of time. And then I put it's easier we thought. So the background work was a lot and it took a year and a half. But like I said, the buy-in, once I presented, it was there and we had the support. And once we had set up this background work, actually rolling it out in the clinic was like, I was kind of weirded out because it went so smoothly. We taught the ACE science and the workflow and we rolled it out and there were almost no hiccups. It just went. And the staff handed out the questionnaires and the physicians did the coding like they were supposed to. And as we rolled it out at the other medical centers, there's been like some questions here and there, but generally speaking, there wasn't a lot of hiccups along the way. So if you do good background setup and get your support, actually putting it into the clinics, it goes well. I think you really need to do thorough training for this to work. Your physicians and your staff have to be comfortable with what ACEs are. They have to be able to talk to it to their patients, and they have to understand what it is in order to talk about it and teach it. And then making that workflow standard across the clinics but malleable so it can fit each clinic's idiosyncrasies helps a lot, and it makes it easier on the physicians doing this if you can work it into what they already do. And then providing scripting for the staff and the physicians helps a lot also. The last learning I think is probably our biggest, and this is the follow-up. So everyone always wants to know, how did you roll out this screening without having really like set in stone follow-up procedures to do? And the answer to that is, and it may be because I was at SCPMG and not a private clinic, but I couldn't convince people to set up good trauma-informed care and follow-up resources within our organization without showing that we had a need for it. So I forged ahead with the screening despite that, knowing that it's not the greatest, right, for our patients, knowing that, yeah, we're gonna screen you and we may not have perfect follow-up yet, but now, a year and a half later, I can show you these numbers. And you're like, look, 40% of our 13-year-olds have ACEs. We clearly have a need in our population. So now let's do this. Let's set up our resources for our patients that need this done. And it's getting a lot more traction now with the Medi-Cal ACEs Aware Initiative as well. So we are developing more community partnerships through our community benefits and through our social medicine teams. We're working more closely with behavioral health to get specific referrals to trauma-focused therapists and better kind of closed-loop follow-up. So I don't just say, you know, go to the community and go to therapy and good luck. It's like, no, I get feedback and I want to see what happens to my patients when they go get this help. Insurance coverage, if I'm going to send them to an outside community resource and they have Kaiser coverage, well then, you know, we should be helping them do the co-pays for those services too. And so that's probably our biggest learning, is that last box there. And then our future plans, we've done this maintenance of certification project. We're looking at the resources, we're expanding it to our entire region for the California Medi-Cal requirements, and we actually have like 2 or 3 other research projects in the works now for this as well. And that's it.